My name's still Jim Morris. And I could tell you a funny story about that, but I'll pass. James Morris and I worked in the Sacramento DA's office for 17 years as a prosecutor. I was appointed to the Superior Court bench in 1984 by George Duke Magian. Retired after 20 years in January of '05. Continued to work on a part-time basis when needed, and diagnosed finally for Parkinson's in '08. But during that time, I've been married to Jerry. My wife this coming month, or in June, will be 49 years. And I have two sons. They're grown and working, both married to beautiful women, and they both have kids, so I have a total of 5 grandkids. Oldest one just started driving, and the youngest one is about 12 years old. So we have a blast whenever we get together. I'm lucky. What more could anybody ask for? And so that, I look at my Parkinson's, I look at my blessings as far as the family's concerned. Parkinson's comes in second, of course, way down. And it's a state of mind. I would hope that everybody who is suffering from the disease does the most that they can to maintain a positive state of mind. That overcomes so much, I think, as much as the exercise and the movement and medications. The state of mind and the I'd put exercise second, and I'd put, sorry doctors, medication third. There's a significant amount of pain. I do have balance issues, I do have gait issues. I have to concentrate to avoid them, and I can. Exercise at home by doing what we love to do, and outside the home. You professionals, therapists, trainers, help us. And when we get that out of you, we've taken the extra step, and you have with us. Thank you. Hey, doctor. Let's hear from Dr. Suketu Kandar.
Hello, everyone. My name is Suketu Kandar, and I'm a neurologist. More importantly, I'm a movement disorder neurologist. I work at Kaiser Permanente in Sacramento. This ParkinsonWISE program was designed for non-medical providers who are providing wellness programs for some of our patients with Parkinson's and other neurodegenerative conditions. So this is an opportunity for us to engage wellness community and really train them on how they can better approach our Parkinson patients. Your objective today is really to gain some insights from medical providers to understand better how you can approach our Parkinson patients and how we can make a better opportunity for this patient population. Parkinson's disease is a neurodegenerative disorder that actually has no cure. It is progressive in nature. Most patients who are going to come to see you are going to know this. However, that's not what we're going to focus on. Just because there's no cure does not mean there isn't treatment, and there aren't ways in which we can functionally help our patients. So some things to remember about Parkinson's is that it's a spectrum disorder. Not everyone is going to fit into one specific category or what is classically described as Parkinson's disease. There are various things that may commonly thread these folks together, but the reality is this is a tailored diagnosis. Therefore, every single patient is going to look different, is going to have different onset of symptoms, a different response to medication, a different set of symptoms, and a different course trajectory, which makes every patient individual, and you have to approach them that way. There are 4 major cardinal symptoms of Parkinson's disease. Number 1, and what we typically categorize as a Parkinson feature, is resting tremor. Not tremor when they're actively doing something, but more importantly, tremor when their hands are at rest, maybe just sitting in their lap or holding a remote control or turning the pages of a book. This tremor tends to be of low frequency, sometimes high amplitude. If you might all remember the tremor that Muhammad Ali had when he lit the torch at the Atlanta Games in the '96 Olympics. That's typically what people tend to visualize when they think about a Parkinson tremor. But that doesn't only define what a Parkinson patient may have when it comes to motor symptoms. Just about 2/3 of Parkinson patients ever really exhibit a tremor. However, the vast majority of Parkinson patients have stiffness in movement, otherwise known as rigidity, or slowness in movement, otherwise known as bradykinesia. In fact, the bradykinesia, or the slowness in movement, is the hallmark of the condition. There is a fourth cardinal sign, and that would be postural instability. That is the difficulty in being able to keep yourself upright without feeling a sense of falling over. More importantly, falling backwards. Interesting enough, it's these four cardinal signs that even Dr. James Parkinson himself first described 200 years ago with his original manuscript, The Shaking Palsy. What are some of the preclinical, non-motor signs of Parkinson's disease that tend to predate the motor symptoms from when they happen? There are four such symptoms. Number one, the loss of sense of smell, otherwise known as anosmia. The second, constipation. The third, sleep issues, sometimes related to things such as vivid dreams or acting out those vivid dreams, or restless leg syndrome. And then the last is anxiety or depression. These four things, the anosmia, constipation, sleep issues, and also the anxiety, can predate the motor diagnosis by as much as a decade. And oftentimes your clients or your patients will tell you that they think they had the Parkinson's long before the doctor made the diagnosis. So first start with the psychiatric issues. What are some of the psychiatric issues that patients tend to experience? We've already talked about anxiety. We've already talked a little bit about depression. But they actually can also develop hallucinations or even psychosis, mainly from the medications that they're being exposed to. And this may impact how you interact with your client. Second thing is the dysautonomia. So we have three different components in our nervous system. One is the central nervous system, that's brain and spinal cord. The other is the peripheral nervous system, and that's the entering and exiting nerve roots that come away from that spinal cord. But the third is one that's a bit more invisible. It's called the autonomic nervous system. And it really helps to control our blood pressure, our heart rate, our sense of temperature. And these are things that you don't really have a lot of control over. But patients with Parkinson's have less control over. They are more likely to have low blood pressure or difficulty keeping up their heart rate, particularly when they stand up or when they're sitting up, mainly because gravity plays a role. Or they may feel colder than many other patients who are otherwise not experiencing that dysautonomia. So because of this, it may impact how you interact with your client. Pain can be a big issue in Parkinson's disease as well. Not just muscular rigidity related pain to where there's a deep knotting tissue pain, but also a sensory pain that they just can't finger or explain, and they may relate some of this to you as well. Two other issues that we tend to notice a lot in Parkinson's is excessive daytime sleepiness and fatigue. But then because of that, they end up taking a lot of naps during the day, which of course sabotages their sleep at night. So for various reasons, patients with Parkinson's will be more fatigable during the day, and this may impact when you prefer to see them to do your wellness and recovery with them. The other thing that they may experience is a change in their vision. If they were to go see their ophthalmologist or an optometrist, they may actually say that their vision is normal. But the reality is many of them have a hard time focusing at things just directly in front of them. It's called convergence insufficiency, but certainly a component of Parkinson's disease. So if you are mindful for all these non-motor symptoms, you'll appreciate what it is that these patients experience, and hopefully it will tailor whatever it is that you're trying to achieve with your patient. So now that you all have heard a little bit about the motor symptoms and non-motor symptoms of Parkinson's, you might be interested a little bit to understand why these patients of Parkinson's have developed these symptoms. So for that, you have to have a better understanding of the anatomy of the brain. So deep within the brain tissue, there is an area called the basal ganglia. The basal ganglia is responsible for initiating movement, maintaining movement, and sustaining our movement. And there are various structures within the basal ganglia that help to make that happen. Now, typically everything in the brain is a chemical to electrical pathway. So there's a chemical that basically surges, and then that ignites an electrical pathway that allows us to do certain things, from our brain to our body. So the chemical that's most often responsible for the pathology of Parkinson's is a chemical called dopamine. Dopamine is produced in an area called the substantia nigra, and Unfortunately, in Parkinson patients, they start to lose the ability to produce dopamine. Now, typically dopamine is created in the substantia nigra, and those electrical impulses that shoot out from the substantia nigra go to the motor cortex, allowing us to be able to move. So lack of dopamine or reduction in the production of dopamine causes us to be stiff, slow, and ultimately develop a tremor. So a lot of our focus of treatment, a lot of our focus and energy revolves around increasing those dopamine levels. Historically, a lot of our treatment revolves around supplementing dopamine. And that's why most of our medications help to promote the level of dopamine. If improving the dopamine levels was the sole treatment for Parkinson's disease, there would be no need for physical therapy or no need for increased motility for a lot of our Parkinson's patients. But we know that's not true. So there must be other factors involved when it comes to promoting overall well-being, both motor well-being and mental well-being when it comes to the treatment of Parkinson's. There's quite a bit more that we still have yet to learn about what other neurochemicals are involved in this whole pathway that leads to the pathology of Parkinson's disease. Still, most of our medical treatments and even surgical treatments revolve around improving those dopamine levels, but I believe that doing physical therapy, particularly at an aggressive level, helps to promote the improvement of all neurochemicals in Parkinson's disease, thereby improving the overall well-being in Parkinson care. Back in the late 60s and the early 70s, Sinemet, otherwise known as carbidopa-levodopa, was FDA approved for the treatment of Parkinson's disease, and it was revolutionary. And now, even 50 years later, it continues to be the universal gold standard treatment for Parkinson's across the board. But again, it alone is not enough. So you'll find that your Parkinson patients are probably on the most complicated regimen of medications that you've ever seen. And it's interesting because what we're trying to promote is a continual therapy of dopamine, trying to deliver that dopamine in a very continual fashion to where they can be on. Now you're going to hear that word again in the future by some of our therapists. When a Parkinson patient is on, that means that their medications are working. That means that they're more mobile. That means they can actually achieve what you need them to achieve to reach the goals that you need for them. However, these medications can also wear off, which basically means those patients can also turn off. And if they turn off, it makes doing and performing therapy very difficult. So historically, a lot of Parkinson patients who are only on levodopa will take their medications. Typically, these meds take about an hour or so to kick in, and they may last a few hours and then start to wear off. You may want to have them come in when you know that their medications are actually on board, rather than when they're off or wearing off, because they're unlikely to achieve what you need them to achieve in an off state. So you want to be a little mindful of how they take their medications, when they take their medications, and when they think that they're actually on. They also may be on a whole host of other medications for the non-motor symptoms, because typically the dopamine is only helping the motor symptoms, or most of the motor symptoms. So they may be on antipsychiatric medications. They may be on medications to help motility for their GI system to help with constipation. They may be on sleep medications to help them get a better night's sleep. And all of this has to be taken into account. So all these treatments, they're really there to help the cardinal motor symptoms of Parkinson's, maybe some of the non-motor symptoms in Parkinson's. But there are certain aspects to the patient's condition that may not be best addressed by the meds. So for example, postural instability, that propensity to fall backwards, getting stuck, having difficulty getting up and starting to initiate your gait, freezing of gait, difficulty with turns, everything that revolves around walking and balance and stability isn't necessarily improved by the medications that we prescribe or the stimulation that we deliver. This is where you come in. This is really our key point when it comes to greater therapy, more aggressive therapy, and keeping the patient mobile. What we're trying to achieve is them getting around with greater stability and less likelihood of falling and fracturing something. Because that's the one biggest problem in Parkinson's, is if they fall and they actually have a hip fracture or a long bone fracture, it really does invite a hospital visit, potentially an OR surgery, or even a visit to a skilled nursing facility, which will certainly set them back quite a bit when it comes to them achieving greater therapy goals. So your job is really to tailor your therapy around them being mobile, them being able to get around, despite the fact that they may be on optimal medication or even novel therapeutic type treatments. Just as much as it takes a village to raise a kid, it also takes an army to actually help somebody with Parkinson's disease. The neurologist is really just one piece in that whole equation. Physical therapists that they may be seeing at their medical institution may also be just one piece of that. But you all actually are the greater piece in that. You're all community therapists and community wellness providers that are going to be able to fill the gap for these patients who otherwise may not have that support outside of their healthcare institution. But they also may have family support, loved ones, neighbors, and friends who are helping to support them. And it will be important for you to recruit their help when it comes to these patients who may otherwise at times feel disenfranchised, a little disillusioned, somewhat frustrated with their condition, because sometimes it may be just that they're fighting a moving train. So if you can recruit their help in this, it would be immensely helpful. So even though we as physicians are giving these medications and prescribing these novel treatments, and our therapists are giving them a structured exercise program, they still need a little help and motivation to help keep that moving forward. So hopefully I've given you some insight into what it is that your patients are experiencing and why it is that they're experiencing it. But I want to leave you with one important philosophy, is that a successful Parkinson treatment program revolves around three things. Number one, the right diagnosis with the right medication. No matter how difficult that medication regimen may be, that is one piece. Number two, the right physical therapist with the right structured exercise program. This, of course, is where you come in. So a lot of our physical therapists in the medical world, regardless of what healthcare institution they come from, is going to provide a structured program. But the follow-through of that program and how to implement it into daily life certainly falls under your umbrella. But the last piece, the more important piece in my mind, is patient accountability and patient ownership. This is their condition to have, their condition to journey through. Of course, we can help ferry them and show them the way and direct them and educate them, but the reality is they have to ferry themselves through part of this condition. That there are ways in which we can improve their quality of life, helping to empower them to better understand what it is that they're experiencing. And this is also why we decided to pursue ParkinsonWISE in order to engage the community to help support our patients that we see in the medical field. And a very big thanks to the Parkinson Association of Northern California to having the vision to help see this through. So hopefully today will give you some insight on how you can approach these patients and how you can actually better help them in improving their quality of life.